me great pleasure. It gives me great pleasure to introduce our two faculty speakers today for our CPC conference. So first, I want to introduce Dr. Alex Taylor. Dr. Taylor graduated from Williams College. He went on to do his medical school at Northwestern, and then he came to Seattle to do his residency and fellowship. Dr. Taylor has won numerous awards that you can imagine, since we all know him here. He's one of our chief fellows, and he has won numerous awards, including the House Staff Research Award, and he has certainly been a major contributor to the fellowship program as one of the chief fellows. Our other speaker this morning is Dr. Chris Chandler. Dr. Chandler went to University of Idaho and then went to Northwestern to do his medical school training, and then came here to Seattle to do his residency and his fellowship. It's interesting that Dr. Taylor and Dr. Chandler have followed each other during their trails from medical school now to residency and fellowship, and will be actually joining close by to each other when they finish their fellowships in Montana. So thank you guys, and I look forward to hearing the outstanding presentation this morning.
Thanks so much, Dr. Yang. Let's jump right into our Cardiology Pathology Conference. It's my pleasure to be presenting this morning with my friend and colleague, Chris Chandler. We have two great cases to share with you this morning. So let's delve right into the first case. So this involves a 32-year-old woman who presents with the acute onset of some pleuritic chest pain. Further history reveals that she's had years of claudication symptoms in her right arm, and she's recently started experiencing some left arm claudication. She also reports constitutional symptoms over the past several months, which include fatigue and a 30-pound unintentional weight loss. Her past history is also notable for gastroesophageal reflux disease, type 2 diabetes, class 2, obesity. She had a transient ischemic attack some months ago, and then also carries a diagnosis of fibromyalgia, which we'll talk a bit more about. So kind of going into this diagnosis of fibromyalgia, several years ago, she presented to her doctor with just sort of nonspecific pains in her arms and legs, and during a laboratory evaluation was found to have an elevated ESR. There was, at that time, a negative serologic workup for both rheumatoid arthritis as well as lupus, and there was never really a clear diagnosis that was established, and she was treated with basically a hydroxychloroquine for about a year. So she comes to us carrying this diagnosis of fibromyalgia. Her social and family history is shown here. She did not use any substances. She lives in the Seattle area and was from Kenya. Her father had myocarditis. We don't know the details of his myocarditis presentation, also hypertension and diabetes. There was no other family history of cardiovascular disease. Here's her physical exam, and I'll show her pulse exam on the next slide. So I'll call your attention to a few things. She does have evidence of mild upper extremity hypertension, but the blood pressures are pretty symmetric between the right and the left arm. Her BMI is 39.5. Other vitals are all normal. She has a soft systolic murmur at the right upper sternal border. There's no evidence of joint swelling or warmth, and no rashes on her skin. So her pulse exam is striking. I've shown here basically all of these, vascular territories, the pulse strength on the right and on the left. And notice that she actually has absent pulses in several distributions. So she's lacking a right radial pulse as well as ulnar and femoral and popliteal. And on the left side, she has no palpable pulse in the ulnar, femoral, and popliteal regions. The person who was doing her physical exam also noted that there were no bruits in the carotid arteries, femoral arteries, or in the supraclavicular abdominal aortic, or in the sort of renal artery region. But overall, a pretty striking pulse exam with multiple areas of absent pulses. Her laboratory evaluation initially is shown here. Basic labs, including a complete blood count, a comprehensive metabolic panel. These were essentially normal. Note that her inflammatory markers were just mildly elevated. Her high sensitivity CRP was 1.2, upper limit of normal, I believe, is about 1, so just a minimal elevation. Her sed rate was also slightly elevated at 38, and her complements were high as well. She was noted to have a positive ANA. The titer, though, was not actually given, but further serologic testing really didn't turn up any other antibodies. So she had negative double-stranded DNA testing, negative RF, negative anti-CCP, as well as negative ANCA testing. So basically, the takeaway here is just she has mild elevations in ESR and CRP. So, given her presenting complaint of new onset chest pain, she eventually undergoes a chest CT angiogram, and one of the kind of coronal images is shown here. And you'll note that here's the LV, the sinuses of Valsalva, the ascending aorta, and then extending into the aortic arch. There's a sort of saccular aneurysm that starts in the sort of mid-ascending aorta and extends up into zone 2 of the aortic arch. And I've got a nice sort of a 3D volume of the thoracic aorta here. So what you'll note is that here's that saccular aneurysm in the mid-ascending aorta extending into zone 2 of the aortic arch. Zone 2 refers to the region in between the left common carotid and the left subclavian artery. And then to further investigate the abnormal pulse exam, she undergoes bilateral upper extremity arterial duplex ultrasound. These are still images shown from the ultrasound. In the left panel here, this here is the distal portion of the right axillary artery. And what's striking here is the marked thickening in the basically intima as well as the media. So very thickened wall of the vessel. And then similarly here in the proximal left brachial artery, this is the lumen of the vessel. And then this on either side where I'm highlighting is that marked thickening of the wall of the vessel. This is the basically just putting into words what I was just showing you. So on the right side, there was a severe stenosis in the distal axillary artery. And on the left side, there was at least a moderate stenosis in the proximal brachial artery. So she undergoes a transesophageal echo. There was initially some concern that she could have a bicuspid aortic valve with an associated aortopathy. But as you can see here, she has a nice trileaflet aortic valve with normal size and shape of the aortic sinuses of Valsalva. Unfortunately, on this TE, we didn't get a look at the ascending aorta, but even in this biplane image here on the right, you can see the sinuses of Valsalva are preserved. Then you can see the start of this basically mid-ascending aortic aneurysm. So based on the results so far, there was a pretty high clinical concern that she could have a Takayasu arteritis. And so she was treated with high-dose steroid therapy and was also sent to see Dr. Burke in cardiac surgery. And so, based on her, pretty large ascending aortic aneurysm that extended into the aortic arch, she underwent an ascending aortic and hemiarch, basically a replacement with an aortic valve, a resuspension procedure with Dr. Burke. And, as was suggested by the transesophageal echo, intraoperatively, she was noted to have a normal aortic root as well as a trileaflet aortic valve. So at this point, I'll turn it over to Dr. Chandler to go over the surgical pathology. So I'll stop my share here, Chris.
All right, thanks, Alex. Okay, so yeah, I would like to go into the surgical pathology for this case. So we received the section of the aorta. I'm going to show a whole slide image of the microscopy for this case. Unfortunately, we don't have gross images. These are often fragmented sort of specimens. But I think what's really nice is the correlation between the imaging that Alex has shown and what we see on the histology here. So the before you a kind of low power view are multiple sections of the aortic wall. And from low power, I think it's evident that we have variable thickness of the aortic wall. Some areas are markedly thinned and other areas, including here where you can see some pretty significant intimal hyperplasia, are markedly stenotic and thickened. And from a low power, there's little patches of blue throughout. And whenever we see that from low power, we're thinking, well, inflammatory infiltrate. So, aortitis is on our differential here. Now, part of the examination of aortic specimens with aortitis is trying to come down to where do you think the inflammation is sort of localized. And so from this view, you can see pockets of lymphocytes kind of here in the media, as well as creeping out towards the adventitial area. There's also a fair amount of inflammation that is along this intimal surface here. So intima here, and then adventitia here. And as we go along, there's a fair amount of inflammatory infiltrate. Before I go down and look a little bit higher, it's again very obvious that we've got areas of kind of vast disarray in terms of the architecture of the aorta, and some areas like this section that's in the middle of the field, which look relatively normal. So a nice uniform thickness, adventitial fat here. So let's go look a little bit at the infiltrate. And right away, you can see that it is a mixed population. So there are some small blue lymphocytes and a few plasma cells as well here and here. But then one of the things that jumps out is we've got scattered giant cells, these multinucleated cells. And that really kind of helps us in our differential, raises the possibility of giant cell arteritis as well as Takayasu's. This appears to be kind of localized more towards the intimal surface, but as before, it was noted, we've got inflammation that's also out kind of in the adventitia. So one of the tools that we can use to help kind of characterize what this structural damage looks like is an elastic stain, which I think is really illustrative in this case. So this is a VVG stain or Bierhoff-van-Giesen stain, which highlights the elastic fibers. We do this on all of the aortic resection specimens to assess the architecture. And again, this is an area of what normal aorta should look like. Nice uniform elastic fibers, kind of thick throughout the media, nice and stretchy. The adventitia is kind of this thin fibrous layer here with the associated fat. And what's really striking here is there's total loss of elastic fibers you can appreciate in some of these areas that are thinned out. So we see this in aneurysm quite a bit, but marked thickening and fibrosis of the adventitia. So much so that, kind of from the H&E, it's difficult to appreciate that that's happening. And if we go and look a little bit closer here on this area, you can see this disorder and loss of elastic fibers with intimal hyperplasia. And this inflammatory infiltrate and fibrosis that's really centered around the adventitial aspect of the aortic wall. And so the variation, the stenosis, fibrosis, kind of adventitial accentuation really helps in this case. And their findings, which are consistent with or compatible with Takayasu's aortitis. And as Alex is going to go into a little bit, Takayasu's affects the aorta, proximal large arteries, can even affect the pulmonary arteries. And microscopically, really, it's classically divided in two phases. There's an inflammatory phase where it's active inflammation. Usually this is sort of the outer 2/3 of the media, mostly in the adventitia and adventitial fat, creeping along the base of vasorum. And you see mononuclear cell infiltrate with giant cells, and actually well-formed giant cells and granulomas are characteristic of Takayasu's, though you don't see them in every case. And then as the inflammation subsides, kind of this relapsing remitting course, you get a stenotic phase where you get reactive fibrosis and sort of circumferential thickening of the intima, which we saw on the VVG as well as H&E, and this leads to stenosis, which is correlated nicely with the ultrasound findings. Often this intima is kind of hypocellular. You might see a little bit of necrosis and some giant cells like we saw, but the involvement can be patchy. In fact, in our H&E microscopy, you could see a normal section of aorta in that resection. And these phases kind of frequently coexist. So, this is very suggestive of and compatible with Takayasu's, but other things like giant cell arteritis or syphilitic aortitis, which we talked about a few months ago, are on the differential. GPA or granulomatosis with polyangiitis, if there's significant necrosis, would be there. And then sarcoid very rarely affects the aorta, but would be on the differential as well. And so these are some textbook images of what the gross pathology looks like. And so this wrinkled aspect, you can see in the left-hand image, is pretty characteristic of what we see in aortitis. And the wall thickening is very evident here. Whereas on the kind of far left-hand side, relatively normal appearing aorta. And on the right-hand image, again, you've got aortic valve mentioned here on the left, relatively normal appearing aorta, and then this large area of wrinkling and aneurysm where there's involvement by aortitis, and then kind of a skip to a relatively involved area. And just to compare giant cell aortitis, which I think would be kind of the top thing on the differential with Takayasu's, they do have sort of a difference in the involvement by microscopy. So giant cell arteritis tends to be a little more top heavy, involving the intermedia. The adventitious typically spared. You don't really see well-formed granulomas. And the wall thickness is not substantially increased. Whereas in Takayasu's, it's a little more bottom heavy, involving the adventitia, with some inflammatory infiltrates out in the fat, and then also kind of the outer 2/3 of the media. The intima becomes quite proliferative, which is shown here with this bracket in panel B, and you may see well-formed granulomas, but it's not always there. So that's just a quick review of the pathology in this case, and I'll send it back over to you, Alex.
Thanks so much, Chris. Yeah, there's really a great correlation between the imaging findings and then what we see on the pathology here. So that's great. All right, so to wrap up this case, after surgery, the patient was continued on high-dose prednisone with planned taper, and she was started on methotrexate as steroid-sparing therapy. And then there's going to be future consideration of starting her on a TNF inhibitor if she still has active disease in spite of being on both methotrexate and high-dose prednisone. So let's talk a little bit more about Takayasu arteritis. So as Chris went into, it's a large vesical vasculitis with granulomatous inflammation that affects the aorta and its major branches. It usually presents before the age of 40 years. There's a strong, basically sort of a female, it's much more common in women. They're affected in 80 to 90% of cases. And for reasons that are not entirely clear, there's a much higher prevalence in Asia than in other areas. And interestingly, there's sort of geographic variation in the manifestations of Takayasu arteritis. And so I'll go into that a little bit more on the coming slides. So as Chris was describing, the most common manifestation of Takayasu arteritis is basically vascular stenoses. These present in over 90% of patients with the disease. They can also develop aneurysms, as our patient did. So, obviously our patient presented with both, significant stenotic disease, as well as this large ascending aortic aneurysm extending into the aortic arch. For reasons that are not entirely clear, the subclavian and common carotid artery are actually the most common sites of involvement in Takayasu arteritis. Our patient actually did not have involvement of those two arteries, but something to keep in mind. The pulmonary arteries can be involved as well. And then there are case reports of coronary arteritis, but this is certainly not a common manifestation of Takayasu. So, as I was mentioning, there's sort of this poorly understood geographic variation in the expression of Takayasu arteritis. So this study basically found that stenotic disease was more common in Japan, Europe, as well as parts of America, whereas aneurysmal disease was more common in Africa, India, Thailand, and Mexico. So this is based on data from a study, I think from like the late 80s and early 90s. And really in the new era of kind of a genetic medicine, I think we really need further study in this area to better understand the possible genetic underpinnings of this variability in the way that the disease manifests. So the diagnosis of Takayasu arteritis is often delayed by months to years. In our patient's case, she was labeled as having a fibromyalgia, even though her initial symptoms started several years before she was finally diagnosed. Significant vascular inflammation is usually present at the time of diagnosis, and one of the monikers for Takayasu arteritis is pulseless disease, and this is just how our patient presented, with absent pulses in both upper and lower extremities. Our patient had mild elevations in ESR and CRP, as I showed. However, these are not universally elevated in Takayasu arteritis. That is, of course, one of the challenges in diagnosing this disease, is that there's no serologic marker or gold standard diagnostic test. It's really based on a constellation of the patient's symptoms, their findings on exam, their findings on imaging, as I'll go into in the coming slides. And really, the goal is to diagnose this disease at an early stage prior to the onset of severe vascular manifestations. But obviously, that's very challenging because patients usually develop symptoms after vascular damage has occurred. So the current diagnostic criteria for Takayasu's arteritis, this is based on the ACR criteria, I believe, shown here in table 3 of this paper that I've pasted. So the criteria you'll notice are from 1990, so they haven't been updated in 32 years. However, you'll be excited to hear that there are new criteria that are in draft form currently. This is a joint collaboration between the American College of Rheumatology, as well as their counterparts over in Europe, which is called basically a EULAR. So just to go through the old criteria, so there's 5 different criteria. And for the purposes of diagnosis, someone's considered to have Takayasu's arteritis if they fulfill at least 3 of the 5. So our patient had age of disease onset of less than 40 years. She presented with upper extremity claudication. She had absent pulses, I think, in her left brachial artery. So she already meets this based on these 3 criteria. And I think I said that there was 5, there's actually 6 different criteria that are part of this diagnostic algorithm. So other things you can look for would be a blood pressure difference between the arms of at least 10 millimeters mercury systolic, looking for a bruit over the subclavian arteries or the aorta, and then if the patient has abnormalities on imaging. The new criteria basically emphasize that patients can get this disease even into later ages. So they've increased the upper bounds of the age diagnostic criterion to 60, and then recognizing all the different non-invasive imaging modalities that have come to light over the past 3 decades. There are also weighted clinical as well as imaging criteria to make the diagnosis. So these should be forthcoming, I believe, later this year. So as Chris nicely mentioned, the pathogenesis of Takayasu's arteritis is really incompletely understood. It's presumed to have a genetic component, and studies that have looked at this have identified several potential HLA as well as non-HLA loci that may sort of predispose someone to developing Takayasu. And then, as Chris showed in those beautiful histopathologic images, there's a mixed inflammatory infiltrate that reaches the vessel wall via the vasa vasorum. And you often get this intimal hyperplasia from the basically myofibroblasts coming in. And the most common manifestation, as I mentioned, is stenotic disease, but the same inflammatory process can also lead to vascular aneurysms. And that's why our patient presented with both. So this is a figure from the ACR treatment guidelines for Takayasu's arteritis. These were published last year. And so, really the medical therapy is pretty simple. The mainstay of treatment is high-dose oral steroids, and typically plus a steroid-sparing agent. The agent that's most commonly used is a methotrexate, but you can also use azathioprine or TNF inhibitors. And then you basically just follow them clinically, often with serial imaging, to see if this process is getting better, making sure they're not developing new disease. And then if they're clinically stable, you can consider de-escalating steroid therapy first, and then de-escalating their steroid-sparing therapy. And then this just goes through basically what I was mentioning. So given that the vascular inflammation and the damage to the vessel wall is often precedes the onset of symptoms, these patients are often followed with serial imaging as they're on therapy, and then the therapy is tapered based on a combination of the clinical assessment as well as what's happening with their findings on the non-invasive vascular imaging. And if they're stable, you'll de-escalate, and if they have progressive disease, then you'll escalate their steroid and steroid-sparing therapy. So there's a couple more slides on this case. One consistent message that has come out of basically operative trials of patients with vascular manifestations of Takayasu is that active inflammation at the time of vascular intervention predicts restenosis. And so these Kaplan-Meier curves here, this is basically comes from a study looking at 42 patients with Takayasu's arteritis who basically collectively underwent 63 peripheral and surgical interventions, which was a mix of coronary, aortic, and peripheral interventions. They were followed with serial angiography after their procedures. And there were a few messages that came from this study. One is that the cumulative patency rate of vessels after intervention was significantly higher in patients who had, quote, stable disease at the time of intervention compared to those who had active disease. And then I don't show the graph here, but they also found in their Cox model that post-op combination immunosuppression with steroid therapy as well as a steroid sparing agent was associated with better sort of a long-term patency. So really the key when you're sending someone with Takayasu's for vascular intervention is to get their disease basically sort of a medically managed as best as possible, which often means several weeks of high-dose steroids plus a steroid sparing agent. And then once the disease is more sort of quiescent, then they should go for the vascular procedure. This is from a similar study that basically it gives the same message. So these Kaplan-Meier curves are basically looking at freedom from a disease, sort of a progression, or needing basically a repeat vascular procedure. And so I'll just kind of go through the curves here. So group 1, shown in the solid line, are patients who do not have active disease and who are not on steroid therapy. The second curve here is patients who do not have active disease but are on steroids. Group 3 are those who have active disease and are also on steroids. And group 4 is those who have active disease but are not treated with steroids. And so what you'll see first is that patients who do not have active disease, groups 1 and 2, do better than those who do have active disease. Not surprising. This is the same as the study I just showed you. But then, if you have active disease and you're not on steroids, group 4, you're going to do worse than if you are treated with steroids, group 3. And then, I think the most striking comparison is between group 2, which are patients who do not have active disease on steroids. They're on basically a sort of a adequate therapy compared to patients who have active disease and are not on adequate therapy. I guess that one other thing I'll point out is that most studies that look at vascular interventions in Takayasu's look at patients who had vascular stenoses. In this study, there was only actually one patient who had an ascending aortic aneurysm repair. So there's really a paucity of data that tells us what outcomes will be after a vascular, or after a surgery similar to what our patient had. And then the last slide in this case, I just thought these were really neat images. So, as I mentioned, the patients often have severe vascular damage prior to the clinical manifestations of Takayasu's arteritis. And so the sort of hope would be that over time with non-invasive imaging, we'd be able to make the diagnosis earlier and get patients started on therapy sooner prior to the vascular damage that comes with longstanding Takayasu's arteritis. A couple of imaging modalities that are starting to be used in this arena include F18, FDG PET CT, as well as PET MRI. This is a beautiful image, PET image here on the left panel, basically showing the ascending aorta. It just totally lights up, and someone with, as well as both, common carotids, and someone with very active Takayasu's arteritis. This is something you would definitely want to target for steroid and steroid sparing therapy concurrently. And then these two panels on the right here are from a patient who underwent a black blood MRA examination. So this protocol basically it sort of suppresses flowing blood, and it highlights the wall of the vessel. And so you'll notice that there's marked thickening of both the aortic arch as well as the pulmonary artery. So this is someone who's has active disease both in the in the ascending aorta and aortic arch as well as the pulmonary arterial circulation. So I think this is probably what the future of vascular imaging and Takayasu's arteritis is going to look like. So most patients with Takayasu are going to have steady, basically a progression of their disease. A relatively small minority, about 1/5, have a monophasic self-limited illness course. But as I alluded to earlier, in most cases, chronic immunosuppressive therapy is really needed to keep the disease from, or basically to keep patients in the stable phase of this disease. So the summary for this case, Takayasu's arteritis is an idiopathic large vessel vasculitis that typically affects young women, and for reasons that are not completely understood, is more common among Asians. As I mentioned, new diagnostic criteria are forthcoming, and these will update the 1990 ACR criteria that we currently use. The manifestations of tachiostro arteritis include most commonly vascular stenoses occurring in over 90% of patients who have the disease, followed by aneurysms. The other points are that it not only affects the aorta and its major branches, but can in some cases affect the coronary arteries as well as the pulmonary arterial circulation. And as I showed with those two operative studies, operative outcomes are better during periods of quiescent disease and when they're performed in the background of adequate medical therapy with glucocorticoids as well as steroid-sparing agents. So in the interest of time, we'll move on to case 2 and we'll take questions for both at the end. Case 2, I believe, is a little bit shorter. So this is a 19-year-old woman with no prior cardiac history who was referred to our institution in cardiogenic shock. So she was previously healthy until about a month ago when she developed some upper respiratory symptoms. She had negative testing for COVID-19 as well as influenza, but she was presumed still to have viral myocarditis of some etiology. So she was started on inotropes and then transferred up to us for consideration of heart transplant. So she had no prior cardiac history, but she did have a history of class 3 obesity with a BMI of 40. She had autism as well as anxiety. Her social history revealed just occasional tobacco use, but no recreational drugs, no kind of a methamphetamine or cocaine use. She was experiencing some housing instability at the time of her presentation. And on querying her about her family history, on her mother's side, both of her mother's parents had developed heart failure as adults, but she had no first-degree relatives with cardiomyopathy or cardiovascular disease. So here's her physical exam when she came to our institution on inotropes. You'll note that on inotropic therapy, she has a blood pressure in the normal range. She's tachycardic to the high 120s. And she has evidence of intravascular volume overload with elevated jugular venous pressure, but otherwise nothing of note on exam. As expected, based on her clinical exam, her B-type natriuretic peptide is elevated. She had negative urine toxicology screening, and then sort of a limited workup for causes of non-ischemic cardiomyopathy did not show any abnormalities. And I don't show it here. I believe she also had coronary angiography at her index presentation prior to transfer that did not show any coronary artery disease. So I'll show a couple images from her echocardiogram on presentation to our center. And so what you'll note here is basically severe left ventricular systolic dysfunction. You'll also note these prominent sort of trabeculations in the apex, as well as extending up here along the lateral wall all the way up to here. Her right ventricular function looks to be maybe mildly decreased, but the cardiomyopathic process seems to be mostly affecting the left ventricle. You can see her left atrium is also markedly dilated, and the interval septum is bowed to the right atrium, consistent with elevated left atrial pressure. Here's a somewhat foreshortened apical 3-chamber view, but I think it's a nice demonstration of just sort of that the papillary muscles look a little bit abnormal. They're not completely characterized on this examination. And you also get a sense that there are these prominent trabeculations as well in the apex and extending up into the lateral wall here as well. So based on this initial echocardiogram, there was some suspicion that she could have a non-compaction cardiomyopathy. So she was referred for a cardiac MRI to better characterize this. And thanks to Dr. Krieger for putting these images together. So I'll walk you through the panels. First on the left here, this is a 4-chamber, basically a cine image of right ventricle up top here, which looks to have essentially normal systolic function and size. But then left ventricle is markedly dilated with a severely reduced systolic function. Her left ventricular ejection fraction, I believe, calculates to 18% in this study. And you'll also note that she has these prominent trabeculations that you see, starting in the apex, but then really extending all the way up the lateral wall. And we sort of got a hint of this on echo, but it's better characterized on cardiac MRI. And as I'll go into, there are numerous criteria for the MRI diagnosis of non-compaction cardiomyopathy using the Peterson criteria, which are the most sensitive diagnostic criteria for non-compaction. She actually, this MRI would be consistent with a non-compaction. So we'll talk about that more. And then there was no late gadolinium enhancement on the PSIR sequences, as shown here on a short axis, as well as a two-chamber view. So just to round out her history, she was temporized she was actually discharged from her index transfer to our institution on basically home milrinone. But she, with the hope that that her LV function would get better and that we'd be able to, wean her off of inotropes, but that didn't happen. Her BMI decreased to 36. So, and some of her social issues, the housing instability, those issues were fixed. And so she was able to go on to get a heart transplant at our center. And I'll turn it over now to Chris again to walk us through the surgical pathology of her explanted heart.
Awesome, thanks, Alex. All right, so for this case, I'm going to start off by showing the gross pathology of her explanted heart. And I'll start just with orientation, because this is you're missing a few things. So these are transatrially resected when they are explanted. So most of the atria, which would be up here, are absent. Really what we're left with is a little bit of atria, the valves, and the ventricles. Left ventricle is on this side. We've got our mitral valve here. Similarly, left ventricle here is sort of cut through coronal plane, just behind the aorta, and the anterior half of the heart is on the left. So one of the things that's striking initially is you can really see this left ventricle is globoid. It's very dilated, it's sort of expanded, and the apex of the heart has been kind of flattened out. It has that globoid appearance. The other thing that is striking is down towards the apex, and correlating nicely with the imaging is this area of fairly prominent trabeculation. So it kind of creeps up onto the lateral wall of the left ventricle. And a little bit of blending that goes into with the papillary muscles, which when I was grossing the heart, I kind of first noticed seemed a little bit abnormal. Looking through the rest of the heart, the right ventricle is really not terribly atypical, no valvular abnormalities that we really appreciated. And there's a little bit of kind of coarse trabeculations throughout the left ventricle. We see this in cardiomyopathy quite a bit. So looking at axial sections of the left ventricle, and again, these are kind of incomplete because of the original coronal section that was taken, but the prominent trabeculations really come through. This is kind of from apex up towards base as you descend from the top of the image down to the bottom. You can see the right ventricle kind of peeking out here on the left as we cut through. And it's really asymmetric. So in some areas, the trabeculations are not particularly pronounced, but in some regions, they occupy approximately half of the myocardial thickness, which we'll get into a little bit here. So let's look at the microscopy for this. So this is a section of one of those areas of the left ventricle, which had the prominent trabeculations, sort of the endocardial aspects here on the right-hand side of the image. And you can see the epicardial fat over here on the far left. And from this view, you can see the areas of trabeculation with the interspersed spaces occupy approximately half of the myocardial thickness. And if we go down and take a little bit closer look at some of these areas of trabeculation, it looks like all of the spaces, all the vascular spaces are in continuity with each other, actually in continuity with the left ventricle chamber, and there is a little bit of endocardial thickening. You can see in this example here where there's just a little bit of pronounced endocardium, and it's really not uniform on the kind of opposite side. On the left-hand side of the image, the endocardium is not terribly thickened. Looking through, one of the other things we kind of take a peek at is whether there's much fibrosis. And there's a hint here and there that there is sort of interstitial fibrosis, particularly in this field here. And this is in this kind of irregular pattern, which we often see in cardiomyopathies, including dilated cardiomyopathy. But really not any other major structural abnormalities of this heart, and really apparent in this section. And maybe a little bit of myocyte hypertrophy at high power, but not anything too pronounced. So again, kind of the main finding is we've got this kind of roughly half of the myocardial thickness taken up by this kind of accentuated trabeculations. So this was interesting to us because in correlation with the imaging findings, we said, well, this could be compatible with left ventricular non-compaction, which is known to be a cause of cardiomyopathy, generally thought to be congenital, characterized by these increased ventricular trabeculations and really genetic underpinnings. And it's thought to be this failure of regression of the kind of normal process the heart undergoes during embryonic development. Instead of the myocardium compacting into a nice solid wall, you still have these prominent trabeculations. And numerous genes have been implicated, and it may be different in pediatric populations versus adult populations. Some are listed here. From a pathology perspective, the thing that we really look for are a few things. Sort of the thickening of the myocardium, usually it's in the left with really prominent trabeculations, is sort of the hallmark. And often this is accompanied by absence of well-formed papillary muscles, and it tends to be more pronounced down near the apex. So, a gross exam of this heart, it's raised our suspicion. And then by microscopy, the trabeculations occupy greater than 50%. We're sort of right on that cusp in this case. And you do have these slit-like irregular myocardial spaces with the kind of variably thickened endocardium. And one thing that is absent in our case, which has been described in the literature, is this compressed rim of myocardium on the external aspect, which was really not apparent. Sometimes that's occupied by actual division with a fibrous band that you can see by microscopy. Those findings really weren't there. So, the differential from a pathologic perspective is maybe this is just prominent trabeculations due to some other form of cardiomyopathy. In this case, dilated cardiomyopathy would fit, and could just be normal anatomic variation as well. So these are a couple of gross images taken from textbook, which really show classic cases of non-compaction. And you can see the prominent trabeculations in kind of figure B with this asymmetric distribution is probably the case that's most similar to what we had, but it can be completely filling the chamber, as in the case here on panel A, as well as panel C, and this involving the right ventricle as well, not just the left. So quite a bit of variability, and I guess the way we signed it out is compatible with non-compaction cardiomyopathy. It's not like definitive, and so room for discussion, I would say, on this one.
All right, thanks so much, Chris. So let's talk a little bit more about the controversies and challenges in diagnosing as well as risk stratifying patients with the phenotypic finding of left ventricular non-compaction. So as Chris very eloquently stated, left ventricular non-compaction, or LVNC for short, is characterized by prominent trabeculations, these deep intratrabecular recesses, as well as thin-walled compacted myocardium. As I was mentioning, a challenge with this phenotypic finding is that this can be seen in normal hearts, as well as physiologic conditions that dilate the heart, namely athletes who tend to get chamber dilation, patients who are pregnant, as well as those who have sickle cell anemia. But as I'll show, there is clearly a pathologic form of LVNC. This is actually considered a primary a genetic cardiomyopathy by the AHA, and it really has heterogeneous manifestations, and we'll talk about this. So this is a paper that was published in the Lancet, I think like 6-7 years ago, and they basically laid out this framework for the different phenotypes of LVNC. So you can see that even though it's called LVNC, there are some types that predominantly involve the RV, where you get RV hypertrabeculation. And there's also an association of LVNC in many forms of a congenital heart disease. Most studies of non-compaction don't include patients with complex congenital heart disease, but those with simple lesions who also have LVNC are typically part of these studies that I'll show. So, I mentioned that the AHA considers LVNC to be a primary genetic cardiomyopathy. So what are the genetics of LVNC? It's become clear that there are both familial as well as sporadic forms of this phenotypic finding. When they do genotyping in studies who have the phenotypic finding of LVNC, the genes that most commonly emerge are sarcomeric genes. So I thought this was a nice pie chart here showing the prevalence of different genetic mutations. So note MYH7, TTN, MYBPC3. You'll also note that these are genes that are commonly associated with other types of cardiomyopathy as well. So with hypertrophic cardiomyopathy, we often see mutations in MYBPC3 and MYH7. I think another interesting thing that comes out of genetic testing studies of patients who have the LVNC phenotype is that, at least in this one study I found, there were no pathogenic variants found in patients who had the isolated phenotypic finding of LVNC, but no LV dysfunction or other features to basically suggest a genetic syndrome. So this was a seminal paper in the cardiac MRI literature, which involved a registry review of 700 patients who were sent for cardiac MRI. The indications for the MRI are shown here on the right side. All these were patients who had a separate clinical indication for cardiac MRI. About 1/5 were sent for MRI to figure out the cause of a cardiomyopathy, 17% for coronary disease, 15% for valvular disease. You can read the rest here. The mean left ventricular ejection fraction of this cohort was 51%, plus or minus 17%. A pretty high proportion, 32%, had late gadolinium enhancement. And there are a couple messages that came out of this registry review. So one is that the prevalence of left ventricular non-compaction is highly variable depending on the imaging criteria that you apply. So that's one message. And also, if you use the Peterson or Stacy criteria shown here, it's an extremely common finding. So these are patients where there wasn't initially any suspicion that they could have left ventricular non-compaction cardiomyopathy, but using the most sensitive criterion, the Peterson criteria, which looks at the end diastolic non-compacted to compacted myocardial ratio in a long axis view, 39% of their cohort actually met diagnostic criteria for LVNC. The Stacy criteria are somewhat more specific. The Jacquier criteria are similar to the Stacy criteria. I'll note that on echo, we use the Jenny criteria. The Stacy criteria are essentially the same thing, but just for cardiac MRI. And that's looking at the end systolic non-compacted to compacted myocardial ratio in a short axis view. One of the newer criteria called the Koptour criteria, this looks at the overall, it sort of uses a complex mathematical model to look at the overall, like a complexity of the myocardial trabeculations using something called the maximal apical fractal dimension. So this is the most specific criterion, but it's not yet been really clinically validated. So these are just some representative images from the paper showing, how the diagnostic criteria are applied to MRI images. So with the Peterson method, so using a long axis view, measuring the non-compacted myocardium shown here with the white line, and then dividing it by the thickness of the compacted myocardium. If that ratio exceeds 2.3, that's considered abnormal and compatible with LVNC. The Stacy criteria, same as the Jenny criteria for echo, same thing, a short axis view, and systole, measuring the non-compacted to compacted myocardial ratio. So this is the other key message from this paper is that, so this is an ROC curve ROC curves for the composite outcome in the study, which was all-cause mortality, ischemic stroke, ventricular arrhythmias, as well as hospitalization for heart failure. So the overall event rate in the study was about 18%. As expected, independent predictors of this composite outcome included age, presence of diabetes mellitus, abnormal left ventricular ejection fraction, abnormal right ventricular ejection fraction, as well as the presence of late gadolinium enhancement. But as you can see here from these ROC curves, this is the line of unity, running up the center here. And there's essentially, all these ROC curves for the four different MRI criteria that were investigated in the study. They all sort of hug that line of unity. So the message here is that there's really no difference in adverse events in patients with and without the isolated phenotypic finding of LVNC by any of the four cardiac MRI criteria that were studied. So what's come out is really that that abnormal left ventricular ejection fraction predicts adverse outcomes with LVNC. So this was a similar study. This was a retrospective longitudinal multi-center cohort study of patients who met either echo or cardiac MRI criteria for LVNC, relatively large, almost 600 adults, an EF that was on average just mildly reduced at 48%. About 18% of this cohort had LGE on MRI. And they had a pretty high event rate. So over a median of 5.1 years of follow-up, 38% had at least one major adverse cardiovascular event. The individual breakdown is shown here. Most common events were, heart failure hospitalization, followed by VT-VF. And so the two messages that they came away with, one is that lower LVEF independently associated with the first major adverse cardiovascular event. And then the presence of late gadolinium enhancement on cardiac MRI was associated with the two most common outcomes of heart failure and VT-VF in patients who had an EF that was in the mildly to moderately reduced range, but greater than 35%. So based on this study, they proposed that the isolated finding of LVNC probably does not confer additional risk if you have a normal LVEF, and if your EF is mildly reduced, if you don't have LGE, that's a favorable prognostic sign. So they proposed this safety algorithm for risk stratifying patients with the phenotypic finding of left ventricular non-compaction on imaging. And so that's shown here in the bottom row. Basically among patients who had a normal ECG, had a preserved left ventricular ejection fraction, no late gadolinium enhancement on cardiac MRI, and no evidence of like a sort of a familial process going on with other family members having similar findings. In their cohort of almost 600 patients, there were 0% like long-term adverse cardiovascular events that were found. So this, I think this is probably the strength of this paper, is that if you really meet all these criteria, you can be you can have pretty high confidence that your patient's not going to experience a major adverse cardiovascular event. The other controversy in LVNC is basically the risk of thromboembolism. So there's theoretical concern that slow blood flow in the intertrabecular recesses would predispose to thrombosis. But when they've really delved into this, the rates of stroke and systemic emboli really are comparable to those rates that were seen in trials of patients with chronic systolic heart failure, with ischemic cardiomyopathy, as well as dilated cardiomyopathy of other etiologies. And the rates that came out of this study was basically 1.54 per 100 person years. And so, a conclusion that sort of comes out of the literature is that the isolated phenotypic finding of LVNC is not an indication for anticoagulation. The question of what to do with patients who have LVNC plus an abnormal left ventricular ejection fraction, there's like a 2C recommendation to consider anticoagulation for primary prevention of LV thrombus in those patients. But that's based on very sort of a limited data. So takeaways from the second case of left ventricular non-compaction. So as I hope I've showed, LVNC is really a heterogeneous entity with variable clinical manifestations. The isolated phenotypic finding of LVNC is likely benign. But when you see that, if the patient has an abnormal EF, or if they have a mildly to moderately reduced EF with late gadolinium enhancement on cardiac MRI, each of those findings independently predict the onset of major adverse cardiovascular events. And so, I think given the challenges with LVNC, one is I think we need to really codify the diagnostic criteria. There's as I showed, there's so many different imaging criteria for LVNC. I think if we could, in cardiology, just settle on one sort of like gold standard for the diagnosis, that would be helpful. And then when we do identify this, I think also codifying the sort of a risk stratification algorithm would be helpful. And the study I showed, I think goes a pretty long way into helping us do that. With the most helpful things really being getting a cardiac MRI to look for the LVEF as well as the presence or absence of LGE. With that, these are my references as arranged by the PubMed ID. I'm happy to share these if people are interested. I'd like to thank Dr. Yang so much for moderating the session today, Dr. Owens, Dr. Krieger, and then all of my co-fellows, and of course, Dr. Chandler for the fantastic path images. So with that, I'll end here. We've got about 6 minutes for questions.
Alex and Chris, great job. Those are very interesting cases. I think, the first case, I think it really highlights the challenges with diagnosing something like Takayasu's arteritis. I think the signal that she had a TIA in the past, I don't know what kind of imaging she might have had done during that workup, which certainly might have maybe accelerated the process of diagnosing her earlier, but obviously we don't know all the details about that initial presentation since she was so young. and to have a vascular event certainly is something that perhaps should have been thoroughly evaluated. I think additionally, she's overweight. So for somebody to do a thorough physical exam to identify that she had absent pulses in her extremities also was quite remarkable, because I think that would be something that would not be done very carefully and certainly could have been missed. So whoever was able to sort of carefully do that assessment, I think is a testament to the importance of physical exam. Alex, I think there are a few questions. I know that you answered them, but I'm not sure they were visible to the audience. So
Sure.
Dr. Steiner had a question, I think which is important, is the family history, since you mentioned that clearly there's a potential genetic hereditary component to it. So she asked if we knew anything about her father's myocarditis, and then can we somehow link those presentations?
Yeah, that's a really, really good question. As far as I'm aware, there's, so with Takayasu, you can get the coronary arteritis, but, other than that, I'm not aware of any cardiomyopathic process or myocarditis that is in itself associated with Takayasu arteritis. So I don't think that there's a connection there.
All right, great. And then Dr. Eschenroder asked about the imaging modalities that would be sort of preferred to diagnose the patient. So I think you went over that, but just to reinforce this point to the audience would be great.
Sure. So, most commonly a CT angiogram is the first line test. I think it's also important to consider doing an MRA instead of CTA. Recognizing that the most common sort of demographic of patients who are presenting with Takayasu arteritis are young women. So probably MRA. I also showed in this patient's case, she had the beautiful, basically like ultrasound images too. So that's, in patients who don't have a very large body habitus, I think that's also a good place to start.
All right, great. And the final question comes from Dr. Stempian-Otero. So he asked about genetic testing in the second case of probable non-compaction. So as I think you pointed out, maybe there aren't great sensitivities to diagnosing this, but can you comment on that?
Yeah, so and that was actually one of my first questions when I started, going through the chart in this patient's case. So, she was initially felt to have viral myocarditis, and I don't think an additional evaluation was pursued for, a possible sort of a genetic cardiomyopathy. But I totally agree that would be very helpful in her case. Because if she does have one of these, pathogenic, findings, that has implications for her, overall sort of a prognosis.
All right, great. I think we're almost out of time. And I think if there aren't any other questions from the group, wait, something else came up.
Yes, we have a few questions.
Okay.
Q&A, it looks like, yeah.
I think we answered them all, did we not? Oh, no, sorry. So Q&A. Whoops. Dr. Dechek, maybe I missed this, but if one has low EF and LGE, one has a sick heart and should expect MACE. Does adding left ventricular non-compaction to those two findings increase the risk of MACE significantly? Yeah,
I think that's a really central question. The way I interpret the studies is no. I think it's really the presence of a low EF and not the left ventricular non-compaction that confers risk of MACE. And similarly, it's having LGE that also confers risk, which has been shown in other clinical contexts. So at least the way that I see the data, the finding of LVNC by itself, or in combination with a low EF or LGE, really doesn't confer additional risk.
Great.
But I think this is really an area that needs further much sort of a closer scrutiny and study.
Yeah, I think given the low frequency of this diagnosis, it's certainly going to be hard to try to really get any sense of how these things are prognostic. Dr. Perry asks, regional differences may also be due to environmental factors such as diet. Did you come across anything like this in terms of Takayasu's?
Yeah, that's a really intriguing thought. No, I haven't seen any literature looking into that. But yeah, thanks for raising that possibility.
And the last question is, do the trabeculae shorten in systole and do they have normal strain? That's an interesting question.
That's a really good question. So yes, the trabeculae do shorten in systole along with the other parts of the myocardium. And so I haven't seen any studies looking at strain. I know you can do really elegant strain analyses with cardiac MRI in particular. And so I don't know if this has been published on looking at the strain of the excess trabeculations, but certainly something that could be investigated in the future.
I think with the advances in imaging, I think that certainly could provide some opportunities to look for these as potential prognostic indicators of clinical outcomes, or help potentially in the diagnosis if we had a large enough series to evaluate that.
Right.
Okay, I think we answered everything. We are just on time. And I want to thank Drs. Taylor and Dr. Chandler for their excellent summaries of these really interesting cases. So thank you everyone for joining us today.
Thanks so much, Dr. Yang and Dr. Chandler. Have a good Friday.
Everybody.